Okay, welcome everyone to today's Explore MedTech Innovation Seminar presented by the MedTech Talent Accelerator. My name is Jesse. I'm a program officer in biomedical engineering at McGill University. And as many of you hopefully know, the MedTech Talent Accelerator is a national training program designed to launch the next generation of industry-ready talent for the Canadian medical technology sector. The program is a collaboration between McGill, Toronto Metropolitan University, Dalhousie, University of Calgary Biomedical Zone, and MedTech Canada and its member companies. Today, we have a very special seminar as part of the MedTech Talent Accelerator Hackathon, which is a virtual 3-week event that started last week. And today's speaker will give a very unique perspective and insight for our hackathon. The hackathon challenge this year is improving throughput of hospital emergency departments. And our speaker today is Dr. Noreen Kamal, Assistant Professor of the Department of Industrial Engineering at Dalhousie University. And she'll present a seminar describing emergency department operations from the perspective of industrial engineering. Noreen is a professional engineering and PhD who is an assistant professor at Dalhousie. She's been working to improve stroke treatment and care for over 10 years. A significant aspect of her research is to reduce the time to treatment for stroke patients. She helped cut treatment times in half in Alberta and is currently working to improve access and efficiency of treatment for stroke patients across all 4 Atlantic provinces. And before we get started, I would like to do a land acknowledgement. So McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and Anishinaabe nations. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which people now gather. And without further ado, Noreen, the floor is yours.
Wonderful. Thank you very much, Jesse, for that introduction. It is an absolute pleasure to be here. I will just get started here. There we go. It's going to minimize the video here. So I am, as Jesse introduced, an assistant professor in industrial engineering at Dalhousie University. However, I'm here presenting from Calgary. I think the introduction was perfect. I don't have too much more to add. I will be speaking about emergency department operations overall from my perspective. I have worked on emergency department improvement prior to becoming an academic and prior to doing my PhD. I also did a fellowship at the Ministry of Health in Victoria and British Columbia, where the objective was to improve emergency department operations. So I have some experience with that as well. So without further ado, I'll get started. I just want to say that this image is not of an emergency department, but one of the beautiful historic buildings on the Dalhousie campus. So as an outline for my presentation, I will start with an overview of emergency departments. Then I'll get into some of the factors that cause long wait times. I will speak about national emergency department data sets that are available that people can view to see how different provinces are doing. You can stratify by age and different things as well. So it's just a good knowledge to have and also to use as you guys are working through your solutions. And then I'll get into what can be done in terms of and has been done to streamline emergency department operations. So first, I just want to do an overview. I'm sure you guys know this, of the health system In Canada, health care is delivered provincially and is paid for by the taxpayers of the province and federally through transfer payments. So it begins with the taxpayers, and that's collected through income tax and sales tax. This is distributed between the federal government and the provincial government. Here we have the legislature here in Halifax. And then the equalization payments from the federal government feeds into the provincial governments. Then the provincial governments have full control over delivery of healthcare. So this goes into the provincial budget and goes into what is typically called the Ministry of Health. Out here, they call it the Department of Health and Wellness, and they then run our healthcare system. So from here, most of the money that the provincial government gives is to the health authorities. In Ontario, it's a little bit different. It gets fed into the individual hospitals. So in Nova Scotia, there's a single health authority called Nova Scotia Health Authority. There's also the IWK, which is across all 3 maritime provinces for children. And from here, we get the health authority budgets, as I said, Nova Scotia Health, the IWK, and this essentially pays for all the hospitals, and they pay the salaries for the nurses. There's engineering involved in it. There's some public health. There are some clinics, mostly specialty clinics that get funded from the health authority budgets. The actual primary care clinics are I'm getting a notification to admit people. Okay, perfect. And most of this comes out of the health authority budget. One big thing that's omitted here are physicians. Physicians are paid directly from the provincial government. They bill, there's billing codes for them, and typically that's done on a fee-for-service basis. There are alternate payment programs, APP, called different things in different provinces, where physicians can get paid per shift, but however, that money again comes directly from the provincial government and not from the health authority. So that is an important piece for you to keep in mind. And from all of this healthcare, whether it's the hospitals, the clinics, the physicians, is the delivery of the healthcare to the people of the province. So let's move on into the actual anatomy of a health system. And really, I would say at the heart of it is the emergency department. Let's start at the bottom. This is our community. This is where most of us live. We don't live in hospitals. We don't live in long-term care. We live out in the community. And from here, community members can access healthcare through our family physicians. We go into their clinics, which are mostly run as private businesses, but we don't pay out of pocket. They bill the provincial government for every patient that they see. The family physician can then recommend that we see a specialist and punt us over to a specialist. They're definitely the gatekeepers to specialists. And if we do need surgery that's scheduled, we can get a scheduled surgery and be admitted to the hospital. Sorry. The other way into the hospital, which is, I would say, about 70% of all hospital admissions, is through the emergency department. So people within the community go into the emergency department. From the emergency department, I would say about 80% of patients are discharged home, or they get admitted. Yeah, can I just request people to mute? And then it's less disruptive unless you have a question, and then feel free to interrupt me. So from the emergency department, they can be discharged home, which is the majority of all admissions into the emergency department, or you get admitted to the hospital. And they're two very distinct groups of patients that we should keep in mind, okay? And then from the hospital, there's various discharge dispositions, it's called. So you can be discharged home, which is this line down here. You can be discharged into long-term care. You can be discharged into another acute care facility or another specialized hospital, such as a rehab hospital, or you can die in hospital. Okay, so it's just really important to keep in mind, and a lot of my students get confused about this. They think going to an emergency department is getting admitted to the hospital. That's not true. It's a way to get admitted, but the majority of patients that flow through the emergency department are not admitted to the hospital. I'll point out that everything is connected, and in fact, at the very heart of I think the healthcare, as I said before, is the emergency department. So there's a demand for care that comes from chronic illness. This is, asthma, diabetes. We can have chronic conditions such as HIV and AIDS has become chronic now. Cancer in many cases can be chronic as well. There is trauma, which are, accidents that occur. This is fed in by driving habits. It could be fed from driving conditions and road conditions. It could be workplace conditions. How good is a province at preventing workplace accidents? And similarly with chronic diseases, the more province or a population invests in prevention and intervention, you sort of reduce chronic illness or allow patients to manage that chronic illness. There's mental illness, of course, as well, and that's a significant oversight often within our healthcare system. And then there's acute illness. This is where you get an illness that can be cured and you get better out of it. And all of this is impacted by the size and population mix. Are we in a province with older people, such as Nova Scotia, or younger people, such as Alberta? And all of this creates this demand for care, which is fed mostly into this emergency department. So what is impacting the emergency department? We have, primary care. Is there a lack of family physicians? About 20% of Nova Scotians are without a family physician right now and on a wait list to get into some sort of practice. And even those that have a family physician can often wait 2 weeks to see them. So there's not a lot of options other than going into the emergency department. And then, as I said, from the emergency department, you can go to the acute hospital, which is the admission to the hospital. And then from the hospital, you can go to nursing care or home care. And we'll speak to all of this. This is just a system dynamic model that I had built while I was doing my fellowship in British Columbia. So let's look at the overall flow of what happens once you're actually in the emergency department. You start with triage, and triage then assesses how severe the patient is and the priority level of the patient. Then the patient is registered. There's an initial assessment by a nurse. There's then a physician assessment. They may or may not order labs and radiology. Labs can include things like blood work. Radiology can include an X-ray, an ultrasound, a CT scan, all of that sort of stuff. And then from that gets reviewed again by the physician. There's diagnosis and treatment that's done. And from there's some sort of discharge disposition. Do the patients get discharged home, or are they admitted to the hospital? So a very central piece of the emergency department is called CTAS, which is the priority level of the patient. So often people say, oh, I waited in the hospital for 3 hours or 4 hours or 5 hours. We need to think about what the level of urgency of that patient was. It's not that someone who requires resuscitation is waiting 5 hours, okay? So a CTAS 1 are patients that require resuscitation immediately. They immediately go into the emergency department. Resuscitation means that they need to get the heart going again, get the patient breathing again, anything to sort of prevent death in the patient. CTAS 2 is an emergency. They need to get seen very quickly. It's not a resuscitation situation, but it's a very emergency situation that, if it's not dealt with quickly, could end in death. CTAS 3, which is actually the majority of most patients that end up in urban emergency departments, a little bit different in rural because of lack of family physicians. We see urgent patients. CTAS 4 is less urgent. They may be some cuts that don't sort of get to any sort of artery, could be a broken bone. That would be a dislocation would be in CTAS 4, and CTAS 5 are not urgent patients. So these are the discharge dispositions. I've spoken to some of them already. As I said, the top 2 ones are the main ones. About 70 to 80% of the patients are discharged home, and about 20 to 30% of patients are admitted to hospital. And these 2 groups will have very, very different length of stays within the emergency department. A discharged home will have a much shorter length of stay in the emergency department, and those that get admitted to hospital will have a much longer length of stay in the emergency department. The other one, which is often a really good measure to use as a quality measure in how well the emergency department is doing, is left without being seen. These are patients that went to the emergency department, but they left without being seen by a physician. There was no diagnosis made. Often when there's very, very long wait times, the left without being seen, which is often abbreviated LWBS, is quite high. So it's a good one to look at to see overall how the emergency department is functioning. And we do have patients that die in the emergency department. Okay, so what are some of the factors for long or extended wait times? So there's inflow. I spoke to some of this already, and this is what's causing a high or higher than normal, or just a demand for emergency department services. So the first one is that there's too few family physicians. There's no option. That's the only way you can seek medical help. There are seasonal factors such as the flu season. We saw this in the news throughout December. It's starting to wane now as the flu bug has gone through, and this was exacerbated this season by a supply chain issue with medication as well. So whenever the flu season comes around, we see huge attendance within the emergency department. We see large bed boarding in the emergency department, which we're going to see in the outflow. We'll talk about that a little bit as well. The third one is just poor health promotion and disease prevention within the province. So that could be high smoking rates, high obesity rates, high rates of chronic diseases. If there's poor mental health services within the community, again, the emergency department becomes a catch-all for those patients. And there could be poor safety regulations, poor behavior of drivers. So high traffic accident rates. I think Nova Scotia is #1 for that. Yay, way to go, Nova Scotia. And high workplace accidents. How is there a culture of safety? Is that able to prevent it? So all of this will affect the demand for emergency department services. Now, there's also issues with people getting out of the hospital. And most of it is coming from admitted patients. So patients that need to get admitted to the hospital, but they can't because the hospital is full. There are no beds in the hospital. So patients are, quote, what's called boarded in the ED. They need to go to the hospital to receive treatment, but they can't. So because there's no beds available, and they just get, they take up space in the emergency department, which means that people coming into the emergency department can't be seen because there's no beds available for them. And this is often exacerbated with long-term care. It's a domino effect. So long-term care is full, so the hospital can't discharge patients to long-term care until a bed becomes available in long-term care for them. Or often what we see is there's regulations, such as there's a flu bug going through our long-term care facility. We're not taking any new patients, even though there's 10 beds available. You know, there's issues like that as well that happen. So then hospitals are boarding long-term care patients, which is called ALC days. How long do patients spend in a hospital waiting for an alternate level of care? And in which case, you know, they can't free up beds for the emergency department patients. That's that domino effect. And then I guess the other one is, of course, what is happening in the emergency department itself. Obviously, the emergency department can't change the inflow and the outflow situation. That's more or less beyond their control, but there are some things that affect the emergency department. They don't have enough staff, and we're definitely seeing global issues around this in all sectors, but especially in healthcare. Staff are sick. This has been exacerbated by COVID. Patients are tying up beds waiting for lab and imaging results, or there's different bottlenecks at different places within the emergency department process. So in industrial engineering, there is a mathematical model called queuing theory. I'm not going to get into the math model itself. Some of you guys may be familiar with it. If not, I do suggest you learn about it. But essentially, the queuing theory shows us, and in that you can have different prediction models for arrival rates of people entering the emergency department, because it's not something that we control. The people don't schedule visits to the emergency department. So a decrease in wait times for patients results in an increased idle time for physicians and nurses, for the staff, or what's called in queuing theory, the servers, okay? So a simple system with multiple servers, which is most emergency departments. There are rural emergency departments that may just have one physician and one nurse working at any time. But most emergency departments will have multiple physicians, multiple nurses. So a simple system with multiple servers, a 35.5% utilization to achieve a 30-minute wait time. So, you know, the other 64.5% of the time is idle time in order to actually achieve this very, very short wait time. If we had a utilization as high as 85.3% of our servers, then it would result in a 7.7-hour wait time. So this is something to think about, especially if we're in a fee-for-service system where physicians are getting paid by patient. Are they willing to have such high idle times so that when patients do arrive, they can get served immediately? Okay. How will the physicians get paid for this idle time? Okay, now I'm going to just talk a little bit about National Emergency Department data, which is quite rich. It's not as good as hospital data, which is 100% outside of Quebec, of course, where we know how many hospitalizations have occurred, how long people have stayed in hospital, what the discharge dispositions are. We are starting to get very, very good national ED data, especially in Ontario, which has 100% reporting of that. So this is done by CTAS, which is our National Institute for Health Informatics. And the emergency department data comes from a database called NACRS, the National Ambulatory Care Reporting System. It includes emergency department data. I've mostly only used it for emergency department data, but it also has outpatient surgeries and other stuff in there as well. The hospital data that I referred to briefly is called DAD, the Discharge Abstract Database. So in here, and I'll just say, so DAD, we have all hospitals reporting other than those in Quebec, which report separately. But NACRS is still voluntary, so it's variable, the amount of provinces that or hospitals that report. So, you know, we have 100% reporting in Ontario, and then it's variable after that. The data collected by CTAS National Ambulatory Care Reporting System, NACRS, provides valuable insight into emergency department visits and length of stay reported by participating provinces and territories in Canada. Okay, so here's some key findings from NACRS. I just pulled this off the CTAS website. So reported emergency department visits rose to almost 14 million visits in 2021-2022, up from 11.7 in the same time period in the year previous. The volume of visits has almost returned back to pre-pandemic levels. So in pandemic levels, there was a decline, and now we're back up to pre-pandemic levels. While emergency department visits climbed to near pre-pandemic volumes across all age groups, the largest increase was observed in the youngest age group, which is 0 to 4 years old, where volumes almost doubled from just over 567,000 in 2020-2021 to more than 1 million in 21-22. Consistent with previous years, patient admitted to hospital in 21-22 had longer ED stays compared with patients who were discharged home. So I've already talked to that. Remember, there are two very different groups of patients, those getting discharged home from the emergency department to those getting admitted to hospital. For those admitted to hospital, 9 out of 10 visits were completed within 40.7 hours. This is the entire length of stay. And for those who were discharged, it was 7 hours. So a huge difference, right? For admitted patients, ED stays were longer in 21-22 than in 2021, the year previous, and 9 out of 10 ED visits were completed within 40.7 hours versus 33.5 hours respectively. So in the previous year, it was 33. So we're seeing almost a 7-hour increase for the admitted group. 2021-2022 data shows that COVID-19 was the 4th most frequent main problem diagnosis, up from 10th in the previous year. And abdominal and pelvic pain and pain in the throat and chest continue to be the most frequent main problem diagnosis in the emergency department. So this is just high-level findings. This is some data that I actually pulled off of the CTAS website, which shows emergency department visits. So here we have in the black line the number of ED visits in thousands, and then we have the ED length of stay. So you can see the ED visits overall, you know, going up and down by month. You can extend it out over multiple years as well. And the length of stay is sort of steadily increasing. There is sort of a decline in February, March of 2022. This is last year. And here we have the overall number of ED visits and length of, so the top one was for admitted patients, and this is the overall ED visits and length of stay. So this looks fairly steady generally, and the number of ED visits, in fact, went down a little bit in January, February. So I just sort of threw the slide in. I did some quick screen captures of the data that I downloaded just to say there's a lot of data available, and encourage you guys to look through it again. And we can see data by provinces, stratified by age. We can see different levels of hospitals, large urban teaching hospitals, large community hospitals. You know, we have small community, medium community hospitals. And you can also get it by diagnosis and things like that. So a really rich data set. Okay, so this is what we're all here to solve, which is streamlining ED operations. So I've just picked a few of them, which there is quite a bit of evidence around, has been trialed in many places. Not all of them are technical. As an industrial engineer, we don't always look for technical solutions. We look for process improvements. So the first one is the Rapid Assessment Zone, abbreviated RAS. This is typically for CTAS 3 patients, that middle group that is attends most often in the emergency department. So the first question is, I've just thrown in some citations here of papers you can look at, which would be good. So do CTAS 3 patients need a bed? They're ambulatory patients. Do they need to be tying up a bed, especially when they are waiting for lab results, which can take 30, 40 minutes? You know, you're just sitting in a bed waiting, or waiting to go to the CT scanner, waiting for an X-ray, waiting for the results, all that sort of stuff. They can be sitting there on a bed for an hour or more. So with the rapid assessment zones, they use recliners to save space and free up beds. Utilization for the initial assessment of intermediate acuity patients, which is CTAS 3, who are stable enough to wait in a chair, but require a stretcher for assessment and or intimate examination or procedure. So when they actually need to be assessed, they use the bed. When they're waiting for the lab results, they can be moved to the recliners or chairs. Patients have their investigation started, wait for results and or receive treatment in a chair or stretcher. So the rapid assessment zone attempts to improve access to care for some of the more complex acute ambulatory, meaning that they can stand up and move around, emergency patients currently being forced to wait for a stretcher space. The other one, change idea or a streamline option, which is used quite extensively, is this idea of fast track, which is for the lower acuity patients, CTAS 4s and 5s. And essentially, often when you go into an emergency department, there'll be a completely separate area that almost functions like an urgent care clinic. And then, so the CTAS 4s immediately after triage get diverted into the fast track area. It creates a separate area with dedicated staff. There's lower acuity patients can be treated more quickly. Just hearing some background noise if you want to mute. Sorry, it asked me if I wanted to mute. I hope you guys can still hear me. Okay, so can this be, and then the other idea is COVID allowed us to show us that we can actually do many things virtually clinically. So CTAS 5 certainly can be done virtually, and this may be an idea to remove the non-urgent patients from the space of the emergency department. Oops. The other one is the creation of it's called different things often, clinical treatment units, CTU, or diagnostic treatment units. And essentially, it becomes a buffer space between the emergency department and the hospital. It's still under the jurisdiction of the emergency department, but it's really for patients that would only require maybe a 1 or 2 day stay in hospital, but that ends up being a really, really long emergency department stay. And it allows more patients to get discharged home from the emergency department, and it frees up space in the hospital. Often a patient that may only need an extra 24 hours to confirm a diagnosis, to see if the patient is going to get better, ensure that there's no secondary effects of a treatment. They can, if they end up in hospital, it ends up being almost a 5-day stay, whereas in the emergency department in one of these DTU units can be a 24-hour stay. So it's a way to actually streamline hospital operations. So it takes patients and their families away from the activity of the emergency department in a quasi-inpatient ward atmosphere. Most often, patients are discharged home from the diagnostic treatment unit, so it prevents a hospital admission for higher acuity patients. The other idea that I've seen used quite nicely in Calgary is this idea of load balancing. And if there's electrical engineers out there, they'll know this concept quite well in how different priority packets of information get sent around, and you want to balance across multiple servers. We can actually use that same ideology in an emergency department. So one way would be to publicize. It works best in urban environments. So publicize wait times for all local emergency departments. Typically what gets publicized are the wait times for CTAS 3 patients, and it allows patients to decide which hospital to go to. Obviously, these are patients that would be arriving at hospital by private vehicle rather than ambulance. Most patients that arrive by ambulance are CTAS 1 and 2, some 3s. And it reduces the load on those emergency departments that are experiencing high volumes. So that is my presentation. I hope that was helpful. And I welcome any questions that folks have.
Excellent. Thank you so much, Noreen. Definitely any questions from the crowd, we welcome. Feel free to write in the chat or go ahead and open your mic and ask away. Yeah, go ahead, Maria.
Okay, so during your presentation, you outlined a lot of the streaming, the things we've done for CTAS 3 to 5 patients to kind of deter them away from the ER. But do you think there's any significant work that can still be done for CTAS 1 and 2 patients?
Yeah, so CTAS 1 and 2, I would say emergency departments actually do an extremely good job, right? That's really how we perceive emergency departments to be, you know, taking big trauma patients that from a big car accident and bringing them back to life, and all that sort of stuff, doing emergency operations and things like that. CTAS 1, if you have actually looked at the data, you would actually see that the volumes are quite low. And similarly with CTAS 2 patients, you know, overall, I think we do a very good job. My stroke work really does look at reducing treatment times for stroke patients, which is a CTAS 2, and we try to push it to a CTAS 1, just as delays in stroke treatment can actually result in greater disability for stroke patients. So we want people to see it as a urgent emergency. But we're really talking about the difference of 20 minutes or 30 minutes, which has a huge impact on a stroke patient, but won't really have a significant impact on emergency department operations or throughput. And I don't think any of what I said should be about diverting people away from the emergency department. I'm sorry if I said diversion away from emergency department. Any other questions?
Very good. We do have some questions in the chat, but priority goes to those who raise their hands and want to speak up. So I see two have raised their hand. Vaishali, you want to go ahead?
You're very, very low. So just if you can speak up.
Yeah, can you hear me?
A little bit, yeah, go ahead.
Okay. So my question is, in our previous presentation, we had the launch of the MedTech. There we saw that the categories made after the triage, and there are some like signs those are like if someone is like CTAS 1, someone is like 2, next, but in practical there are some ways that come in. So my question is, where do you think for
I couldn't catch any of that. Jesse,
Yeah,
were
me
you-
neither. So, Vaishali, why don't you go ahead and write your message in the chat, either to me or Noreen. And in the meantime, we'll let Jeffrey ask his question. Jeff Maxim, please go ahead.
Thank you, Dr. Kamal, for that really interesting. I found a lot of that new to me, actually. So I wonder if you could comment a bit more about, you said you're doing research to improve throughput, I guess, if that's the right word, for stroke patients. What's the balance? Is that mainly paperwork or assessment? Is there anything diagnostically that could be improved, that could improve the throughput for, I guess, CTAS 2 stroke patients?
Yeah, thanks for that, Dr. Maxim. So really it is all about processes and doing things in parallel, trying to be prepared for the patient. So the work actually starts when the emergency or when the ambulance actually calls ahead saying we're arriving in 10 minutes with a suspected stroke patient, who's, and then often, depending on the legislation of the province, you can actually say her name is Mary Smith, and this is the health card number. So while they're en route, they page the specialists who come down and meet the ambulance. They can look up the patient history. The registration is done ahead of time. So the patient comes in on the ambulance stretcher, a quick assessment is done, and they're taken directly to the CT scanner without removing the patient from the ambulance stretcher. So if we think about the old process is wait for the patient to arrive, then call the neurologist, then do the assessment, move them to an emergency bay, do the assessment in the emergency bay, then do the order for the CT, and then move the patient to the CT scanner. So it's really about streamlining and parallel workflow. I hope that helped.
Yeah, and including, moving some of the technologies that are in the emergency room into the ambulances, at least the ones that require rapid assessment and rapid therapy, I guess.
Yeah, I mean, there are CT ambulances, very, very expensive, and often there'll be one or two maximum in a city. So there's one in Canada, it's in Edmonton. Berlin has one, there's a number in the States. The issue becomes when we have an ambulance where there's hundreds in a jurisdiction, and then there's one dedicated for stroke, and they have to drive to the patient, whereas a closer ambulance could have actually got the patient to the hospital faster. So it's a bit of a trade-off because it's such an expensive piece of equipment to put inside the ambulance.
You need small and portable that can be in all the ambulances.
Yeah, there are sort of now swim cap type stuff that is using EEG, and they get slightly better prediction than just a clinical assessment, but it's still not 100% without actually getting a picture of inside the brain, right?
Thank you.
Yeah.
Thank you. We do have a question from Ryan. Do you want to go ahead and ask it? Okay, the question is, you mentioned bottlenecks in patient flow. In your experience, are there bottlenecks that apply to ED departments more broadly, or is this really dependent on a particular ED structure, so rural versus urban, for instance?
Yeah, I do think there's generalizations to be made. It's not my main area of study, but I do think the waiting for lab results ends up being a fairly significant bottleneck, and that's where that rapid assessment zone comes in. I think the other, and often, especially for the less urgent patients, because you will have an urgent sort of lab coming in for a CTAS 2 patient, and they get priority in the labs. So then it pushes people back. And when things are already overcrowded, that becomes a huge weight for patients. Similarly for X-rays and other radiology stuff that needs to get done. So I would put that there as one. And I think the other big bottleneck is just physician availability, resourcing.
Perfect, thank you. So we do have the question from Baishali, the one we couldn't hear so well earlier. The question is, after the CTAS assessment, there are significant delays in each category. For example, the patient needs to be seen 15 minutes in theory, and could actually be seen after 2-3 hours, perhaps. What do you think are the sources of this delay, in your opinion?
Yeah, so it's the CTAS 2. So for each of the CTAS, there's suggested time to physicians. These aren't sort of length of stay in the entire emergency department. This is time from arrival to being seen by a physician. So a CTAS 2 is the 15 minutes. I don't know of any CTAS 2 patients that would wait 2 or 3 hours. I'm just using stroke patients as an example, which are CTAS 2. They get typically seen, I think the longest they may wait is 45 minutes. If they're already changed to a CTAS 3, it might be longer. But CTAS 3 is the big one with that big discrepancy where the guidelines say seen by physician within 30 minutes, and often it can extend into the hours. And the bottlenecks are all, as I said already, waiting for labs and all that. So I won't repeat that.
Okay, and a question from Addie to clarify, are CTAS used all across Canada, including Quebec, just to clarify?
Yep. Yeah, and it sort of stands for the Canadian Triage Acuity scale, but it's actually even used outside of Canada. It was developed in Canada, but yes, yeah, across Canada.
Okay, very good. And I myself was curious about the CT scanner. I'm wondering how good it is at its intended use. If you can maybe expand on that technology, and if there might be alternatives that our hackathon teams could think of how to develop.
So CT scanners, especially for stroke, but for many diseases and many, it is the workhorse of the emergency department of the hospitals. They are quite central for a lot of diagnoses and things along that line. There are a lot of technologies that are coming out of the CT scanner from artificial intelligence. So you have your CT scan, which is your non-contrast CT, and then you have a contrast that's often injected in, and from that you can get a CT angiogram, which shows the vessels. In my case, it's inside the brain, but it could be in any part of the body. And there's also CT perfusion. So there's sort of this softwares that are coming out. I'd have you guys look at Rapid AI, which have automatic sort of prediction. So in stroke, Rapid is saying, oh, this would be a good candidate for a treatment for stroke called endovascular thrombectomy because there's brain left to save. So, it sort of helps the radiologist. I don't think we're looking at replacing the radiologist, but especially in smaller community hospitals where people might have less experience with a disease. The other one, the really sort of nice images come out of MRIs, and MRIs can be very slow, especially from stroke. And they are, there's fewer MRIs. It's really hard to access. So we're now seeing smaller MRIs that can be put in the emergency department. People can get faster access to MRI. The other side of it, and I've seen a lot of interesting research being done, is getting smaller and smaller imaging stuff that might be good enough for stroke, right? Can we put it in a helicopter? Can we put it in an ambulance, which we've talked a little bit about already? So these are areas of interest as well. I hope that answered your question.
Excellent. No, that really helped a lot. And it just raised my curiosity because we just had a seminar in biomedical engineering at McGill on microwave and RF frequencies for stroke. So do you have any, insight on that?
I don't know. I'd love to
Okay.
see some of that research. No.
Excellent. Okay. So we do have another question from the audience in the chat from Jeannie. So the question is there any real-time monitoring on the capacity of each ED so the resources can be better distributed across different EDs or hospitals? So real time.
Yeah, I've seen that load balancing, which is more for patients. And I just, it's a good question. Like how well can resources get moved around and how would that impact a team, right? So we see sometimes we see physicians are only hired at a certain hospital. Are they able to work in a different hospital? How easy is that to do? How easy is it for nurses to move around? And then are there issues with, I don't know where the order sets are kept, or I don't know how to do pharmacy at this hospital. How transferable are things if we were to do it? But yeah, interesting idea for sure. And as we're moving to more and more integrated health records across hospitals, I think we can get to real-time monitoring for sure on capacity issues that might be happening at a single emergency department. It doesn't solve the bed problem. We can't just add a wing with 10 beds, right?
Okay, great. So Dr. Anthony Robert has a question. He's actually a clinician at the ER at the McGill University Health Center and a judge for our hackathon. And this might be our last question of the day. So by all means, Dr. Robert, please go ahead.
Yeah, so I didn't plan to be the last one, but I thought I'd kind of give a nice word of congratulations to Noreen and Kamal for this amazing work. Great presentation. I think your approach on the engineering processes and how you see emergency department really reaches out to me because I'm an electrical engineer by training first before medicine and emergency medicine. So you're the research side, I'm the clinical side of this. I want to make one comment and add a question in the end. So one comment was there's a slide that you had where it shows patients in the community going to a hospital or the family doctor and around. The reality in Quebec is a bit more complex, which I thought would bring up for learners' sake. The patients can go to any environment, such as going to the family doctor or to a clinic and be sent back to the ER, which is another problem where even they might be in the clinic upstairs seeing a cardiologist who will say, okay, you need to go to the ER for further evaluation, which kind of goes to what you had, from home, or instead of going home, they're coming back to the ER. But essentially, it's nice to know that other people are sending patients to the ER because they don't have those resources to do rapid investigations in their clinic and so on. You mentioned about stroke patients, and I think it's really relevant to the emergency department as well. The concept of having, streamlining the process. I was wondering, in your research, what have you seen in terms of patient education and the impact of that? Some of the things that I see personally is patients that come in a day later just because they thought it would get better, or they didn't know if it was urgent or not, but they heard that there's a lot of COVID, they didn't want to come to the ER. You know, I'm talking about hours and days that could be saved sometimes. I was wondering, from what you've seen, were the efforts and impacts of that?
Yeah, it's heartbreaking, right? Because I think stroke ends up being one of those diseases where it's painless, and we hear about emergency department crowding or healthcare overutilization by the media. So we as Canadians are, oh, I'm a tough one, I'm just going to sleep this off, which then brings them outside of the treatment window. Rather than seeking help and calling 911 right away. I actually have not focused a lot on patient education. I've been peripherally involved in some of the research around it. I would say overall, we're not doing great with symptom recognition of stroke. We've done a lot of education out there for FAST, and yet it's not really well when you actually call people randomly and say, what are the signs of stroke? We don't do well in Canada around that. And that is an issue. Like, we as people are trying to do the right thing and not attend the emergency department. And in the end, it ends up being potentially a longer stay in the emergency department, because if they're outside the treatment window, it'll be a CTAS 3, but then a really, really long stay in hospital and even longer rehab and end up in long-term care. So that patient that could have come in and gotten treated in 30, 40 minutes and been discharged home after 5 days in hospital, costing about, let's say, $15,000, ends up costing $200,000 to the healthcare system, and absolutely devastating for that patient and their family, right? Yeah,
you're right. It's definitely heartbreaking to see, because those are actually really good people who wanted to do good by staying home, and they end up suffering the most. So yeah. Thanks for your perspective. Appreciate it.
Yeah.
Excellent. So we are past the top of the hour. So with that, that brings us to the end of today's seminar. Everyone, please join me in a virtual round of applause for Dr. Kamal. Very much appreciate sharing your wisdom and insight today.
Great. Thank you so much for having me. I hope that was helpful and not just a bunch of stuff you knew already. So.